Peripheral nerves have a strictly limited speed for healing. Even under optimal conditions, a damaged nerve can only regenerate at a rate of approximately 1 millimeter per day. Successful repair follows a rigid biological sequence. The body must first clear inflammation, then activate Schwann cells and initiate angiogenesis to grow new blood vessels. Only then can the axon elongate and undergo remyelination. No single pharmaceutical drug currently in existence can replicate this coordinated, multi-step signaling process. Platelet-rich plasma provides a biological alternative. A single blood draw contains a multi-factor cocktail designed to trigger these exact repair phases at once. This chart illustrates the concentration of brain-derived neurotrophic factor in our blood. Platelets store 25.2 nanograms of the factor, compared to the 1.7 nanogram marker found in standard plasma. Regenerating a nerve is a systemic signaling problem that requires a multi-factor biological response. Carpal tunnel syndrome serves as the primary clinical testing ground for this approach, as it possesses the most robust evidence base. Standard corticosteroid injections offer fast-acting symptom relief, but the effects are short-lived. PRP takes longer to manifest, providing a level of durability that typically outlasts the steroid. Fadalaw's 2024 analysis of over 9,000 subjects found PRP superiority holds after 6 months. Chen's study confirms clinical effects are sustained for a full year. This contrasts with AAOS guidelines suggesting no long-term benefit, but their review preceded these recent meta-analyses. The research does show a boundary. Electrophysiology data remains inconsistent across trials. Standard tests focus on large fibers, while many carpal tunnel symptoms originate in small fibers that these tests don't capture. For patients with mild to moderate carpal tunnel, PRP functions as a biological bridge with significantly more staying power than standard injections. Diabetic peripheral neuropathy represents a much larger crisis, affecting 13 million Americans with 0 approved therapies capable of modifying the disease. These clinical studies by Hassanian and El Sayed reveal a significant breakthrough. Unlike standard pharmacotherapy, PRP resulted in both subjective symptom relief and objective increases in nerve conduction velocity. The mechanism is comprehensive. PRP replenishes neurotrophic factors, restores impaired Schwann cells, and repairs the vasa nervorum, the vital blood vessels supplying the nerves. We have to view this data with caution. These are early, open-label trials without sham controls or blinded subjects. Crucially, because these trials lack intraepidermal nerve fiber density measurements, we cannot yet definitively claim that true physiological regeneration has occurred. Despite these limitations, PRP is the only current intervention showing objective functional improvement in a space where standard drugs provide only symptomatic relief. In cases of physical trauma and peripheral nerve injuries, PRP is emerging as a critical surgical adjunct. Kuffler's 2026 research utilized PRP-filled collagen tubes for nerve gap repair. The study reported a 100% elimination of chronic neuropathic pain in the subjects. This timeline highlights a specific timing anomaly. The total elimination of pain occurred well before the nerve could have achieved physical reinnervation. Larger studies, like Shea's 222-patient trial, show that adding PRP to collagen conduits significantly improves muscle strength and nerve conduction parameters. In acute trauma, PRP provides structural healing support while independently neutralizing chronic neuropathic pain. How do we move from these biological theories to a standardized clinical tool? The engineering solution lies in the PCX ultrafiltration device, using a 15 kilodalton molecular weight cutoff. This specific threshold captures dimeric neurotrophins and large antifibrotic proteins like A2M, necessary to stop the formation of scarring around the nerve. Simultaneously, the filter removes small inflammatory mediators that would otherwise cause the platelets to activate prematurely. This process even accounts for nerve growth factor. While a single unit weighs only 13.3 kilodaltons, these units naturally bind together into a larger 26.5 kilodalton dimer, allowing the filter to successfully retain them. Ultrafiltration selectively engineers a precise regenerative microenvironment using these molecular weight cutoffs. The current medical model prioritizes managing symptoms over biological repair, leaving a vast number of patients in a state of partial recovery. This chart breaks down the resulting costs: $2 billion for carpal tunnel surgeries, a $45.9 billion burden for diabetic neuropathy, and a 50% failure rate for complete surgical repair after nerve injury. Relying on symptomatic management strategies alone cannot address the underlying nerve damage. Platelet-rich plasma offers a shift toward regenerative biological repair. While clinical data is still emerging and institutional guidelines are slow to adapt, the physiological signal is clear. By utilizing the body's own concentrated growth factors, we can trigger the natural repair sequence that pharmaceutical drugs cannot achieve. We are moving away from simply masking peripheral nerve symptoms and entering an era where we can finally address the biology of the nerve itself.